All right, Chapter 21. 21 is regarding diabetic emergencies and altered mental status. This is probably actually one of my favorite emergencies to go on, simply because if it is truly a diabetic emergency, many times it's a quick fix and it's a very dramatic fix. But more so because I enjoy when we have the altered mental status, I enjoy trying to figure out the puzzle that goes along with it, trying to get the all the history and pick up on the physical exam pieces and whatnot that help us to determine what is the cause of this altered mental status. They throw these two together because most diabetic emergencies will have some degree of altered mental status, whether it's the dramatic diabetic coma that a lot of times we find are people with low blood sugar in, or the people who just have the slightly altered mental status of the high blood sugar patients, which can eventually also make its way to unresponsiveness as well. Diabetic emergencies, I think, are going to just continue to rise because of, again, because of the lifestyle that Americans lead. We see increasing numbers of children with diabetes these days because of the dietary lifestyles that we all keep. We like our sugars and we like our carbs, so I think that's driving a lot. Number of objectives there, of course. A couple of multimedia slides. The Diabetic Etiology and Pathophysiology video might be particularly poignant for you guys to take a look at, because understanding diabetes a little better would be helpful. Etiology has to do with the cause, so causes, and then what it actually does. So our general core concepts here are going to be, we're going to look at approaches to assessing the patient with an altered mental status, understand those causes, the assessment and the care of the diabetic and various other diabetic emergencies, understand the causes, assessment, and care of seizure disorders, which often go along with altered mental status and diabetes both, and understand the causes, assessment, and care of stroke, as well as causes, assessment, and care of dizziness and syncope. Syncope is the medical term for passing out. So when you have when you faint, you have a syncopal episode. All right, so our pathophysiology, mental status regulation. How do we stay awake? Well, that's regulated by some neurologic circuits in the brain that are composing a particular area referred to as the reticular activating system, or the RAS. The RAS is responsible for our sleep-wake cycle. The RAS is what caffeine, when we drink caffeine, works on, and it helps to stimulate it to constantly keep the brain going and keep us alert and oriented. Requirements for a good mental status, there's the alert mental status is really the three major components that people need to live: oxygen, sugar, and water. So without those, the brain shuts down. So oxygen is needed to perfuse the brain, glucose to nourish it, and then water to keep it hydrated. A significant amount of your brain tissue is water, as is most of your body tissue, but probably more so in your brain. Oxygen and glucose are really the two things that it absolutely has to have up there constantly. The brain itself is actually, when you look at it structurally, fairly simple. But when you look at it from a physiologic standpoint, obviously it's quite complicated. But it has to have that constant bathing of sugar and oxygen. The oxygen gets there via a number of arteries, particularly the carotid arteries feed a significant portion of the brain. There's some other accessory arteries like the vertebral arteries, and then a network that actually goes around your brainstem called the circle of Willis that just branches off, almost looks like a spider, if you will, an upside down spider. There's a circle in the middle with these fingerlings that come off of it, and those feed the brain with the required oxygen, and obviously gets the glucose and the water up there as necessary. The cerebrospinal fluid, which is the clear fluid that bathes the brain and the spinal cord, are essentially water and glucose. There's a few other minor things there, but it's really water and glucose. In fact, if you were to taste somebody's cerebrospinal fluid, and I wouldn't recommend this, but if you were to taste somebody's cerebrospinal fluid, it would taste very sweet, because that's what it is. It's sugar water. So, causes of altered mental status: deficiencies in one of the three major elements is really the main causes there. And that's when we see a lot of our medical emergencies that relate to altered mental status. Either the oxygen is low, the glucose is low, or the water is low. So somebody's ill and become dehydrated. Somebody is diabetic and the sugar's gotten low. Somebody's having shortness of breath and now their oxygen levels in their body are dropping. That's when mental status starts to change. I've talked before that some of the very first signs that we see in people of certain medical emergencies is agitation or a slight change in their mental status. And here's the reason why. I mean, you have just a very slight deficiency. It changes the dynamics up there. Trauma, infection, and chemical toxins can harm the brain tissue. Obviously, if you get struck in the head and break a blood vessel up there, you start to get some bleeding in the brain, and that bleeding puts pressure on the brain, and it makes the brain not function at its full capacity. Infections, of course, you have some sort of an infection, it's going to throw off the balance of everything. Of course, you can get pus pockets that start to fill up in there and build up in there, and when you start putting pressure on other parts of the brain, you start to see pretty dramatic side effects from that. And then chemical toxins. Now, chemical toxins can be actually, if you think about the term chemical or toxin, either one, you can think of them really as something underneath the sink or out in the garage. But this also means drugs or medications, alcohol, and those sorts of things. They all have different effects on the brain. We'll take, for example, some of our sedatives, some of our sedative drugs that we may take, like Valium. Valium just goes, it affects all of the central nervous system and the peripheral nervous system, and it just puts it all into slow motion. Depending on the dose you take, obviously, the more slow motion you're going to be in. So, the primary brain problem, which is a stroke. Strokes, heart attacks, deep vein thromboses, and pulmonary emboli in most cases are the same thing. It's just a matter of where it happens. So it is a blockage of an artery, and everything beyond that the blockage is suffering from hypoxia. So that's really what it is, and it just matters where it happens. You can get aneurysms of the brain, just like you can get aneurysms of arteries other places in the body. So that's a different type of stroke. We have two major types, one that's bleeding and one that's just hypoxia. And then problems within another system, hypoxia due to asthma. So that kind of defaults back to that first one, deficiencies in oxygen. So when we have problems within that other system, the respiratory system can't keep up. Maybe we don't have enough blood in our body to keep blood and high quality nutrients go into our brain, then the brain starts to shut down. We'll take, for example, let's say you're running around and are dehydrated, you're overexerting yourself, and next thing you know, you passed out. Well, why did you pass out? The brain didn't have enough circulation, didn't have enough oxygen, blood, and glucose going to it, so it says, okay, I'm out, and you passed out. And then usually as soon as you hit the floor, you wake right back up. And this happens because blood was then able to easily get to your brain. So to assess our patient with an altered mental status, It's an impressive picture. So safety. The patient with the altered mental status can be dangerous to responders. So when we have patients that we're responding to and it says altered mental status, everybody has to be on their most alert because who knows why this happened. Maybe it's a diabetic reaction, or maybe it's as a result of an assault, and maybe this result of this assault has led this person to become angry or violent. Maybe it's a result of drugs or alcohol. So this can be a very dangerous situation. Good example, when I was a number of years ago, so working in the 911 system, we had a patient we would deal with from time to time, a very well-built farmer, tall, broad shoulders, big guy, obviously worked the land, and he had a very small, petite wife. However, the farmer was diabetic, and he would occasionally, particularly in times of stress like planting and harvest, would start to see a few more diabetic reactions from time to time. And one time I recall going to his house, showing up there very early in the morning and during harvest, and it was all his wife could do to keep him from wiping the floor with her, although both of them were the kindest, gentlest people that you would ever meet. But the diabetes, the diabetic reaction, the hypoglycemia or low blood sugar, caused him to become very angry at this point. We basically had to almost tackle him, sit on him, and then give him some medication to raise his blood sugar. And then when he woke up, of course, he was terribly embarrassed and very, very upset with the way that he had behaved, because that just was not the way he was. However, he had really no control over it. So always consider your safety of yourself and your team before approaching a patient, and use law enforcement when necessary. So hopefully you'll work in a system in which law enforcement works very closely with you, and you can use them at a moment's notice. So your primary assessment, the most common cause of an altered mental status is hypoxia. It may be a very mild hypoxia, but hypoxia is the most common cause. And so you should always consider the possibility of an airway or breathing problem when you're dealing with an altered mental status. Hypoxia, in most cases, is also the easiest one to fix. So if we have a patient who is hypoxic or has altered mental status, oxygen should be one of our first treatments. Even though you've been to this diabetic's house 500 times and you know that their blood sugar is low, they need the oxygen, the water, and the sugar all equally in order to get their brain to function appropriately. The easiest thing to do if we have a cooperative altered mental status patient is give them a little bit of oxygen. That helps stack the deck in their favor. Then we can keep looking for the additional issues. So in the primary assessment, it's not A, B, C, D, S as in sugar, and D, in this case it actually would fall under the D for disability, but A and B come before D. So airway and breathing, we got to support that before we worry about the rest. So oxygen is a good thing here. Doesn't have to be a non-rebreather. It can be a few liters by cannula if necessary. So hypoxia, most common cause of altered mental status, and a lot of times even with just a little bit of O2 we see really good results. Identify and treat any life-threatening problems. So if we have that patient that's hypoxic, if we have that patient that the altered mental status has gotten to the point now in which they don't maintain their airway very well, and this happens fairly frequently, we may need to do something to maintain their airway. With that being said, if you're fairly comfortable with the situation and you feel that this probably is a diabetic reaction, I would encourage you to not hurry up and throw an airway down this person, particularly put a king airway in this person, because in some cases with diabetics, we wake them up rather quickly and easily. However, if they're fully unconscious and out, You've got to maintain the airway. So if you need to, you can start with a jaw thrust or a head tilt chin lift, continue to do your assessment a bit, determine if this is something that we maybe have a chance of reversing quickly, and then work on doing that. Now, if they're fully unconscious, we're not going to give them the oral sugar anyway, so if we need to do on the nasal airway in this person, that would be my recommendation. An oral airway in an unconscious or partial or nearly unconscious person that's a diabetic, like I said, this is actually in most cases a very quick fix. If the paramedics show up and they put an IV in the person, they're going to push some sugar through that IV, and within minutes that person is going to wake up. And so in those cases, we may not want the biggest, baddest airway we can have, because it just actually is going to create problems. Once that patient wakes up and here's this tube down their throat, this could be a problem. So be alert to the need for positioning and suctioning if the patient requires it, or if the mental status worsens. Do we need to roll them onto their side into what we refer to sometimes as the shock or the the recovery position? If we need to put them on the recovery position in case they vomit, and have our suction ready. A lot of times patients with altered mental status will have a significant amount of secretions in their airway, and with that we may need to do a little suctioning from time to time. So in our secondary assessment, we're going to thoroughly examine the patient. If they're exhibiting new, unusual behavior, or even slightly altered mental status, can indicate a serious underlying issues. I think most of us can pick up when people close to us have something going on, and it's very concerning to us. And the underlying cause is what we're really looking for. So the body system exam and complete history may reveal information about the suspected cause. So you need to talk to family members and bystanders. You need to obtain patient baseline vital signs. The family may provide some information if the patient's unable to give it. You may need to go kind of searching around the scene. Don't forget to look for things like medical alert tags. Do they have a bracelet or a necklace or an anklet? Do they have a medication list nearby? Do they have little syringes? If you haven't seen insulin syringes, they're just a very, very small syringe. They're very thin. They only hold 1 milliliter. Most of them hold 1 milliliter. Some of them even hold half of a milliliter, with a very fine little needle on the end of them. Usually they have an orange cap on the needle. Those are insulin syringes, and that could be a good indicator that this patient is a diabetic. Looking for certain medications, if you're looking in your standard places, you usually look in the kitchen, in the bedroom, and in the bathroom. That's typically where we see medications at. One more place to look for insulin is in the refrigerator. Most people keep their insulin in the refrigerator. Insulin can sit out at room temperature. Mind you, room temperature is about 72 degrees or so, but can sit out at room temperature for a number of days and be fine. If the patient has their windows open and it's the middle of summer and it's 95 degrees outside, 95 and 72 are pretty far apart, and your insulin breaks down much faster that way. So if you keep it in the fridge, it stays better longer. So that would be a place to go look. Additionally, they may have sharps containers, which are red boxes that they put their used needles in. You might find those somewhere around. And then a lot of times we also look on the refrigerator. There may be something called a file or a vial for life, which is lists of information. That's the same thing I just was talking about. All right, so what kind of information about a patient's altered mental status might you obtain from the scene? And we kind of talked about that. We're looking for medications and medical devices and so on and so forth. You're also looking, take a look, is there any evidence that there's food in the house? Is the patient able to eat? When times are tough, people may not have as much food as they need, and they're trying to get by on as little as possible. So maybe your diabetic patient has low blood sugar because they just don't have any food. Also, we're looking at the conditions of the scene. Is there something knocked over? Is there like a little kitchen 2 or 3 step stool that they would use to get up into an upper cabinet that's knocked over? Well, we got this little step stool knocked over, or there's something else out of place. Did this patient maybe fall? Because if this patient fell, this may not be really a medical emergency. This could be a trauma emergency. They could have a bleed in their brain that's mimicking a diabetic reaction. So those are some sort of things that you need to look for. How might bystanders help you identify the cause of the altered mental status? They can give you a history, and a lot of times bystanders know sort of, kind of, what kind of medical history the patient has, but they can kind of tell you maybe what's been going on the last day, hours, minutes, weeks, so on and so forth. They can give you a lot of good information. They may not have perfect details, but they can give you a lot of tidbits that can help you put together the puzzle. So we'll talk diabetes. Glucose. Glucose is a form of sugar. It's the body's basic source of energy, and the body cells require glucose to remain alive and create energy. The body takes glucose and oxygen, puts them through a process in part of the cell called the mitochondria, and it creates energy in the form of something called ATP, which is adenosine triphosphate. You don't need to know that, but it puts them through this process and creates an energy source. And when it does this, and it has the correct parts oxygen and the correct parts glucose, it does this very efficiently. When the body is short one or the other, short oxygen or short glucose, it makes it very difficult for the body to do this efficiently, and it goes into a rather inefficient mode, and it can be like 16 times less efficient to do it the other way. So how does glucose in the digestive system work? Well, first of all, glucose molecule is a fairly large molecule. There's a lot of different little atoms and parts stuck onto it, and it does not pass into the cell without insulin. All right, I'm going to bring you back to high school chemistry for a bit and talk about something called a catalyst. You might be familiar with this in your car. There's a catalytic converter. A catalyst is a helper substance. So a catalyst helps something else happen. So in this case, we can consider insulin to be a catalyst. Catalyst number one, insulin, helps us after we've got food in our system. The insulin helps us take the food to places that it is needed, and that sugar is then able to pass into the cell. And then after that sugar is able to pass into the cell, the sugar and the insulin work together. Actually, the insulin helps break apart the sugars and turn it into the correct energy source. So when we eat something, and you see a picture of the pancreas here, and then a blood vessel there and some cells. So when we eat something, we take in food in obviously usually a fairly large form, solid form in many cases. Our body starts to digest it, and starches are actually the first thing that start to get absorbed and put to use. So your salivary amylase, so some of your spit, starts to break down starches the moment they hit the mouth, really. And then throughout its time in the stomach, a lot of the starches are pulled out. So those starches, which are actually sugars, the sugars get broken down, pulled out, and then sucked into the bloodstream. There's a large number of blood vessels around your gastrointestinal tract, and they pick up all these nutrients. The body senses, oh, you ate something, so it starts to secrete the hormone insulin from the pancreas. The pancreas secretes this insulin. The insulin combines with the sugar in the blood vessels, and then when it gets to a cell capillary runs by a cell that needs some sugar. Some sugar is pulled out, the insulin goes with it, and that insulin acts as the RSVP, or the key, to allow that sugar to get into the cell. And then once it's in the cell, obviously it can combine with oxygen in the mitochondria and do its job to create the necessary energy. So diabetes, and specifically I should mention diabetes mellitus, M-E-L-L-I-T-I-S, I'm sorry, I-T-U-S, diabetes mellitus, and you can see that on 508 in your textbook, M-E-L-L-I-T-U-S, diabetes mellitus. This is what people often call sugar diabetes, or most people think of this as the only form of diabetes. There's another form of diabetes called diabetes insipidus that actually has to do with your water. It doesn't really have to do much with your insulin. But diabetes mellitus is a insulin problem. Everybody, when they think diabetes, they think sugar. The problem is usually not sugar. The problem is the insulin. So when we have diabetes mellitus, we have to watch. We're really maintaining an insulin level that help in turn maintain our sugar level. So this insulin is produced by the pancreas, and it binds to those receptor sites on the cells, allows that glucose to pass in, and our sugar intake and insulin production have to balance to allow the body to use our glucose effectively. If we can't create appropriate amounts of insulin, or no insulin at all, we just have sugar floating around in our body. Most new onset diabetics are actually found to have very, very high blood sugars when they're very first diagnosed. Your typical blood sugar for most adults is somewhere between around 70 and 110. That's kind of the average range, and it depends on the lab that you look at as well. Some labs say it's a little higher, some labs say it's a little lower, but we'll just say for the sake of argument, roughly 70 to 110 is the norm. A lot of people who are new onset diabetics might be found to have blood sugars 600, 700, 800. I've seen people with blood sugars over 1,000 when they were brand new diabetics. So there's just all this sugar floating around. The sugar cannot get into the cell because there isn't any insulin. And the body will work to try to remove as much sugar as possible by through the process of urination. But that's very slow and inefficient. So that's why these blood sugars just continue to build and build and build. The sugar intake, insulin production balance, that's what a lot of diabetics have to work with. They're told, watch what you eat, pay attention to what you eat, know approximately how much sugar there is there, and then take X amount of insulin to counterbalance that. So diabetics are taught a lot about this. They're taught a lot about nutrition, paying attention to their sugars, so they know how much insulin to take. If they take too much insulin, they'll burn off all the sugar very quickly, and then boom, they're out like a light. So diabetes mellitus, there are two types. There's type 1 and type 2. Type 1 is underproduction of insulin by the pancreas, and type 2 is inability of the body cell to use insulin properly. So we have these two types of diabetes that plague people. Sometimes people will migrate from one to the other. But to look at your textbook on 508, it describes these a little bit better. Type 1 is formerly known as insulin-dependent diabetes, and that's when the pancreatic cells fail to function properly, and they just don't secrete insulin normally. So these type 1 diabetics just don't have the insulin to do the job that they need, and if left untreated, these glucose levels just build up. These people usually are on some sort of a synthetic insulin via an injection to help them deal with that. Type 2, which is formerly known as non-insulin dependent diabetes, they're still used, these names are still used fairly frequently, occur when the body cells fail to utilize the insulin properly, and the pancreas may be secreting enough insulin, but the body's just unable to move the glucose in and out. And patients with diabetes type 2 will control these usually with an oral medication. The oral medication is not insulin. You may hear things like Dibeta, Diabinase, there's a ton of them, metformin. glyburide, a lot of those oral medications that diabetics are on, those are not actually insulin. Those actually are more catalysts, really, to help the body use the sugars appropriately and use the insulins appropriately. They're not oral insulins, though. So the synthetic insulin is typically prescribed. That's the stuff you usually find in the vial. That's the ones that they usually need the syringes for, and may have the biohazard containers around, or the sharps containers around. Sometimes patients are actually on both oral and shot to try to maximize what they do have. There are some people that make really no insulin, but there are a lot of people who make a little bit of insulin and just need some assistance. A lot of times type 2 diabetics, really, they watch them very, very closely with their diets, their exercise, and then of course taking their oral anti-diabetic medications. People who are type 2 diabetics can become type 1 diabetics. So you can go from managing it fairly well to just needing a little assistance to really you got to go to the shot. You got to have everything. So you got to be careful. So we have two major classifications of diabetic emergencies: hypoglycemia, hypo meaning low, glyce is sugar or glucose, and emia is of the blood. Hyperglycemia is just the opposite, high blood sugar. There are some other names that get thrown around with these. There are some other weird categories that kind of fall within these, but for the most part, we're going to look at these really as a hypo or a hyper. So hypoglycemia, major causes. Diabetic takes too much insulin. Diabetic does not eat. Diabetic overexercises or overexerts, or they vomit after they've eaten. Those are probably the most common ones that you deal with. People that are sick, though, their hormones get out of whack, so what their normal dose of insulin might be might not work for them that day. Might be too much, might be too little. So diabetic takes too much insulin. Remember what I said is they have to kind of pay attention to how much did I eat, how much insulin should I take to set that off. That's called sliding scale insulin a lot of times. And that sliding scale insulin usually is geared more towards what their blood sugar reading is, where after they eat, they may take their blood sugar and say, oh, it's too high, I should give myself a little bit more. So diabetic does not eat. Sometimes this is diabetic does not eat in time. If you go on a diabetic early in the morning, a lot of times it is as a result of somebody got up, decided, okay, well, got to get going for the day. I'm going to go take my insulin. Oh, crap, I took my insulin, but I forgot to go do this. I'm going to go do this real quick, and then I'm going to sit down and eat my breakfast. And they never get back to breakfast. And next thing you know, you find them wet and naked on the bathroom floor because they decided, oh, I'm going to jump in the shower before I eat. So this happens fairly frequently, that somebody they didn't get there in time. So the diabetic overexercises or overexerts. This all obviously depends on the person's lifestyle, but it's not terribly uncommon. Probably more common in the summer when people are outside and being active and they kind of lose track of what's going on. And then obviously vomiting. If you vomit, you don't have the sugar in your system to constantly be supplied. So when you don't have that, you will end up going down very quickly because your sugar source you just had, you just puked out. So signs of hypoglycemia. Remember, hypoglycemia is low blood sugar. Very rapid onset. That's one to keep in mind, is it is a very rapid onset. And with that, if you can compare it a lot of times to the hyperglycemic patient, the hyperglycemic patients typically it takes days or weeks for their gradual decrease in mental status. But the hypoglycemic, we're talking minutes. They went from doing fine to done. May present with abnormal behavior and mimic a drunken stupor. A lot of times when we get called to a potential drunk, we show up, if we recognize them, that's very helpful. But if we don't recognize them, we should probably consider checking their blood sugar, because if they're having a diabetic reaction, they're hypoglycemic, and they're seemingly drunk, and we don't treat that, that patient can die very easily. If they're drunk and we check their blood sugar, the worst that happens is now they have a little pinprick in their finger. They might get a little owly with us, but that's the worst that can happen if they are drunk. So checking the sugar, if we can do that, is a good thing. They usually have pale and sweaty skin. They're usually tachycardic, and they may have seizures. Seizures are not an absolute. The pale, sweaty skin, tachycardia, those are fairly common. But the seizures, that's usually either in a patient who has a seizure disorder as well, or the patient that is really, really low. So what happens when we have hypoglycemia? There's a starvation of brain cells. Those brain cells can't function appropriately. They don't have their energy source that they need. They'll end up with an altered mental status, potentially leading to unconsciousness, and it can lead to permanent brain damage. So that permanent brain damage, on the permanent nerve damage that comes along with diabetes, can be from either too low of sugars or too high of sugars, that the body's just not able to set in its nice, easy homeostatic, which is a kind of the nice equilibrium that the body wants to be in. And it actually harms the nerves a lot. So when we have this constant swing. Hyperglycemia, on the other side, this is a decrease in insulin. Maybe the body's inability to produce it may exist because insulin injections were not given in sufficient quantity. They took too little. One thing that it can be confusing when diabetics are taking insulin is insulin is in units, and units are not equivalent to milliliters. So we generally talk about units being about 10 times that of what most milliliters are. So if you would talk about, or even 100 times, I should say. So if you're talking about a milliliter of insulin, it may be 100 units. So it can be confusing there, particularly people that are early in their condition. They may have an infection. Infection causes the stress on the body. Stress on the body causes the body to pump out more hormones, and sometimes that hormone creates more sugar. The one hormone that typically doesn't get increased in people who are ill or under stress is insulin. Kind of actually the opposite effect. They may have an increased dietary intake. They may be all of a sudden decided, hey, I'm really tired of, really watching what I eat. This week I'm just going to pig out and eat whatever I want. And when they do that, they spike their blood sugars way up. So our signs of hyperglycemia, key one again here, develops over days or weeks. They have a chronic thirst and hunger, so they're really in an increased urination. Those three signs alone usually are enough for most people to say, you should probably go see your doctor because you may be a diabetic now. It's called polyuria, polyphagia, and polydipsia. Those three terms, so the increased thirst, the increased hunger, the increased urination, should be a red flag that people need to go talk to their doctor and be checked for diabetes. If you have a patient who even has a slightly altered mental status and somebody's telling you, yeah, they've been drinking a lot, peeing a lot, and eating all the time, that really should probably be a signal for you. I really need to check this blood sugar because there's a real possibility that there could be something going on here. And then nausea. They may have nausea. They have extra stuff floating around in their body. They need to get rid of it. The increased thirst is trying to dilute the sugar. The increased urination is twofold. Number one, the body trying to get rid of the extra sugar, and two, you've been drinking so much more, now you're going to create more urine. And this increased hunger, and they may be eating all the time, but they constantly are feeling hungry. And this is most likely going to be as a result of the patient knows, hey, I'm not getting sugar into my cells, so it's trying to send signals saying, hey, eat something so I can get some sugar in my cells. Well, there's all kinds of sugar there. It's just not able to get inside the cells and be used. So some results of hyperglycemia: profound dehydration. These people typically become very dehydrated. The body's working overtime to get rid of the extra sugar, and when it does that, you pee, you become dehydrated. Also, there's so much sugar outside the cell, the body wants to say, hey, how do I make the level of sugar and water outside the cell the same as the amount of sugar and water inside the cell? It says, okay, pump out water. Pump the water out of the cells. When it pumps the water out of the cells to dilute the sugar outside, then it turns around and it dehydrates the cell. Excessive waste products are released into the system. When the body has to start breaking down its own cells, its own fat stores and whatnot, it's very inefficient. And when it does this, it creates a lot of waste. It creates a lot of things called like lactic acid. Anybody who's familiar with working out knows that lactic acid is one of the big problems when you start working out and you get stiffness and soreness of your muscles. You can also end up in diabetic ketoacidosis. Well, ketones, which are related to acetone, so that stuff that ladies clean their, well, I guess it doesn't have to be ladies, but people take fingernail polish off with, or I guess guys in the workshop might use a little acetone as paint thinners and whatnot. But the acetone related compound called ketone, and the ketones are a toxin within the body. Diabetic ketoacidosis, they have this excessive amount of this byproduct, this waste product floating around in the system, and it makes them very, very ill. So signs of diabetic ketoacidosis: they have profoundly altered mental status. So they are basically nearly unconscious. They are going to be on the verge, if not completely in shock, so that caused by dehydration. They're going to usually have very rapid, heavy breathing. And that's called Kussmaul's respiration. That rapid, heavy breathing is Kussmaul, which is Kussmaul, Kussmaul respiration. And that Kussmaul respiration is rapid, heavy breathing, the body's attempt to get rid of the extra amounts of ketone in the body. And they can have an odor of acetone on their breath. So you may get up close to that patient's face and then sniff their breath, and it kind of is a fruity, acetone smell. Now, this is not an absolute, and there is a certain number of the population that can't smell this. So it's not an absolute, but if you smell it, you've got probably a pretty good chance that that is what you're dealing with, as long as you kind of have these other signs or symptoms to go along with it. Before I go into assessment, I'm going to throw a couple of terms at you here. Hypoglycemia, hyperglycemia. Sometimes hypoglycemia is also called insulin shock. They have too much insulin, and it puts them into what people consider to be a shock state, whereas DKA is what gets often thrown with hyperglycemia. So there are other terms that get thrown around here. Just if you hear these terms, take a moment to consider what that term means, and if necessary, look it up. Diabetic coma. Diabetic coma a lot of times is referred to as hyperglycemia. All right, so on to assessment. Obviously, assess the scene to make sure it's safe. We have to have that scene safe for us, for our crew members, for any bystanders, and our patients. And then primary assessment, we need to identify altered mental status. Now remember, when we're doing this, we may also note things like that very heavy, rapid breathing. We might note tachycardic heart rates. We may note that their skin is pale and clammy. So those are some things that kind of go along with it that are supporting pieces of material. Our secondary assessment, we're going to look at the history of the present episode, how the episode occurred, the time of the onset, the duration, associated symptoms, any mechanism of injury, because remember, we can have altered mental status for more reasons than just trauma, or I'm sorry, more reasons than just diabetes. It can be from the result of trauma. Or we could be dealing with a complex case in which our diabetic patient, and I've been on this numerous times, diabetic patient wasn't really paying, wasn't obviously within their faculties, decided they're going to get in the car and drive down the road. Well, so you get in the car and you drive down the road and you get into a horrendous crash. Well, now you're injured and you still have a low blood sugar. So you can have multiples. Any interruptions to the episodes, any seizures, any fevers. So sample and OPQRST are very, very critical here if we can get them. Obviously, sometimes we have to deal with what we get from the scene and go with that. So determine if there's a history of diabetes. So question the patient if possible, question the bystanders, look for medical alerts, look for other scene clues such as insulin, syringes, so on and so forth. Now, syringes alone are not a strict sign that the patient is diabetic. People can have syringes laying around the house, particularly if they are into IV drug use. A lot of times they have insulin syringes, but it helps take you down the road. So furthermore, if we're able to, and depending on what your home state or the state you're licensed in allow you to do, you may need to use a blood glucose meter, or a glucometer is what it's called. And this measures glucose in the bloodstream, often used by patients at home, and sometimes EMTs are allowed to use it. In Nebraska, it requires a separate course. All right, so back to glucometer. So with the glucometer, sometimes you are able to carry these in your trucks, as well as occasionally you may use one in the patient's home. So assessment of our patient can be done without a glucometer. We can base it off of our signs and symptoms that we see. However, if we have the glucometer as a means, then we should try to use that to help us gear our further treatment. So blood glucose measurement less than 60 to 80 milligrams per deciliter, 60 to 80 milligrams per deciliter in a symptomatic diabetic is hypoglycemia. Please note that it says symptomatic diabetic. This is going, the reason we qualify it this way is you may have somebody that has a blood sugar of 72 and is doing just fine. Those are patients you probably should not treat. If they are functioning normally and appropriately and their sugar is less than 80, you probably don't need to mess with it. You should probably leave it alone. Some people deal very well with lower blood sugars. I have seen people in the 30s and 40s that are still able to walk and talk. So some people just deal better with lower blood sugars. Others constantly are running high. Anybody less than 50 milligrams per deciliter, it will probably have significant alterations in their mental status. Now, when I said I've seen people 30s and 40s that are still able to walk and talk, they were probably not perfectly on task. So anybody less than 50 really probably is going to need some sort of a treatment. You definitely should be transporting them, if nothing else. Over 140 milligrams per deciliter is hyperglycemia, and over 200 to 300 milligrams per deciliter for prolonged periods of time is going to create dehydration and more serious problems. People who have DKA, diabetic ketoacidosis, usually are in excess of 500. So some glucometers may display a word instead of a number, and in most cases it will give you the number if it's between a certain range and a certain range, and it will say low or it will say high if it's outside that range. So the example they give here is high over 500, low below under 15, because it becomes very difficult for it to fully assess that number. A lot of the meters I've used recently will give you a range of 10 to 600. So depends on the brand and what you're using. So that's kind of the skinny on glucometer. So if you're able to use glucometer, you need to have a little additional blessing and training probably. You need to know your equipment as well. We'll probably touch on glucometer a little bit at a skills session, but we're going to move on now to patient care a little bit. So occasionally we can treat a person with mild hypoglycemia and maybe a very minor altered mental status by giving them something to eat. This is really the best way for this patient to be treated, is something orally that they take in normally and they can absorb and use correctly. Never attempt to administer food to a patient or liquid to a patient at risk for aspiration. If they can't maintain their own airway, you give them something to eat and they suck that into their lung and die, guess who's responsible? So if the patient's able to talk to us and be fairly reasonable and are acting basically appropriately, just maybe not quite as sharp as they could be, we can attempt to get them to eat something. Now, when you give them something to eat, it should be obviously carbohydrate based. So whether that's an oral glucose, and oral glucose is a sugar, a packaged sugar that we carry in many cases, and you can kind of see how they're doing this on page 512 in your text, or it's actual food. We may give them a cookie or a candy bar or even some juice that has some sugar in it that will allow them to get some quick sugar into their body. So if they have a history of diabetes, they have an altered mental status, but yet are awake enough to swallow and maintain their own airway, then something oral is a possibility for these people. So if we're going to give them the oral glucose, we're going to have the patient squeeze this glucose from the tube directly into their mouth. Occasionally we may squeeze some on a tongue depressor and then have them suck it off or lick it off of the tongue depressor. Sometimes we may put just a little bit of sugar on a tongue depressor and rub it on the insides of their cheeks, but we're talking very small amounts because even a little too much can easily get sucked in. So a little something slowly being absorbed through the cheeks is better than nothing. But then again, that's a local protocol issue that you would have to consider what you have locally. So after we've given them some oral glucose, and we usually want them to have that whole tube if possible, we're going to reassess them. And if the condition does not improve, probably contact medical control and ask whether we should give them any more. Just because we've given them some sugar does not mean that they will stay functioning for long periods of time. Sometimes they very quickly will have a deterioration right back into hypoglycemia again. When we deal with patients that we've given something to eat, sometimes they're like, oh, well, I don't want to go to the hospital. I'm feeling fine. I don't want to go to the hospital. Sometimes that pops up. We have to be very strict about saying, if we're not going to transport you, then we really need to sit and make sure you get something of substance to eat. So you may want to consider, if you're not transporting them, making sure that they eat something not only with some sugar, but then also something with some protein. So sometimes I've woken people up by giving them some sugar either via the IV or orally, and then had them say, oh, I don't want to go to the hospital. And then my rule is, okay, well then let's sit down and eat something with protein, either some meat or some cheese, peanut butter. Peanut butter can be kind of a scary thing if they're not fully awake, because it obviously is a choking hazard. But requiring them to eat something with protein, which gives them longer acting sugars. Your carbs, your sugars and starches are good for short term, but you need the protein to keep you going for the long term. So there's a video. There's an example of it's not actually an insulin syringe they're showing you, but it's the same size as an insulin syringe. And then how bottles of insulin would look. They also have a pill bottle there, I guess, to represent the oral hypoglycemics. But that's kind of the normal packaging for the insulin vials over on the right. Before we move on to other causes of altered mental status, if we stop and take a look on 511 in your textbook, figure 21.3 at the top of the page there, it shows an example of an insulin pump. People are becoming a little more familiar with these, but still they're kind of mysterious. And some people think, oh, well, you've got a pager or an iPod on your hip. What is that? And they didn't pay attention that that's not actually a set of headphones coming out of the top of that thing. It's a clear tube, and that clear tube goes to a part of their body in which there's a little needle that's poked into their skin. And that needle is going to stay in their skin until the time comes to move it to a separate location. So that little insulin pump has basically a vial of insulin inside it, and it constantly provides that patient with a little bit of insulin all day. There's some controls on it. If the patient is getting ready to eat, they might hit a button and it gives them a little boost, a little bit of extra insulin. Whereas if they need to, they can dial it down or dial it up a little bit throughout the day if they're not feeling that it's doing the job it needs to. The other thing, some of these newer insulin pumps will actually monitor your blood sugar at the same time as it gives you insulin, and that allows it to very precisely administer insulin. So it'll constantly be sampling blood sugars and then turn around and either spike it up or turn it down in order to meet the need for the amount of sugar that patient has. All right, so also in your textbook on 514, if we look at about halfway through the page there, it talks about hypoglycemia, hyperglycemia compared. This really is probably a good thing to set to memory. Onset, skin, and breath are some of the key differences that we see between hypo and hyperglycemia. People with hyperglycemia don't need any more sugar. They've got tons of sugar. They need insulin. Insulin is not something an EMT can give. So what that patient needs is a ride to the hospital, and potentially either one of these you should certainly be considered calling for ALS assistance to tier with you. Either paramedics can do either give them the sugar IV that they need, or if the patient has some insulin around and their protocol allows it, the paramedics may also be able to give that patient some insulin, as well as some IV fluids in which the hyperglycemia patient would need. So that would be a nice little piece of information to stick in the back of your mind. All right, so some other causes of altered mental status. Seizures, seizure disorder. If the normal brain function is upset by either an injury, an infection, or a disease, that brain's electrical activity can become irregular. So with the electrical activity, and that's what, remember, all of our nerves run off of is really electricity. It's extremely, extremely, extremely low levels of electricity, but that is really how it all works. It's all a very, very, very minuscule little spark. So if the electrical system gets out of whack and sparks are flying everywhere, the body doesn't work in its normal systems, then it throws a person into a seizure. Irregularity can bring about seizures, sudden changes in sensation, behavior, or movement. You probably, if you've ever played a video game, you've probably seen some sort of a disclaimer somewhere either on the package or when you start the game that says these games can cause seizures, and that's very true. It's typically things that are very cyclic. So we don't have anything cyclic in EMS, like a siren that plays the same tone over and over, the lights that flash in the same cycle and beat. Those sorts of things can precipitate or cause seizures. So in many cases, if you are dealing with a patient who is having a seizure, has the potential for a seizure, you should not be using lights and sirens, because you can actually make them have a seizure. Even though the lights are on the outside, most of us probably, if you've been in an ambulance with the lights on, you know that it actually flickers the inside lights a little bit. Every time that the outside lights flash, the inside lights flicker just a little bit. That can be enough. Seizure is a sign of an underlying defect, injury, or disease, and there's lots of different reasons why this could happen. The most common seizure that we talk about is the tonic-clonic seizure. This is what most people consider is an actual seizure. The tonic phase is the body becomes very rigid for up to 30 seconds, so it's almost super tense for 30 seconds or so. And then the clonic phase, the body kind of relaxes a bit, or it tries to relax, but the whole body can't relax at the same time because there's all these electrical signals going everywhere. So the body then will jerk violently for 1 to 2 minutes. And then there will be the post-ictal phase. Please note how that's spelled, because it's not post-dictal, it's ictal. And that post-ictal phase, this is after the convulsions stop. It's a period in which they slowly return back to normal. And this can take minutes to hours. Even some people need a whole day to really come back out of it. So most people that are tonic, or when you're in a tonic-clonic seizure, you are generally unconscious, and you see these things, the tonic-clonic. This is a lot of what people think is the only type of seizure, is when it looks like a fish out of water. They flop around, then they lay there, and then they flop around, then they lay there, and that's not necessarily true. There's some very different types of seizures we run into. Some patients may also complain of something called an aura. An aura is kind of a weird sensation that they get before their seizure happens. This is sometimes when people will tell you, oh, I'm going to have a seizure. They may get out of their chair and lay down. Sometimes they have a significant amount of notice where they will have seconds to a minute or so to change position or do what they need to do. Sometimes it might be, oh, I'm going to seize, and then wham, they seize. This can be weird taste, weird feelings, weird odor, or smells, I should say. So it just changes their senses a bit. So, but it's just sometimes just a general feeling. Sometimes people will kind of get this blank stare on their face as they get ready to have a tonic-clonic seizure. And that may be because they're having another type of seizure just briefly before they start their tonic-clonic seizure. Tonic-clonic seizure is what usually are referred to as grand mal. And a grand mal seizure is meaning the whole thing. It's big and it's bad. We can also have partial seizures, and not all seizures are as generalized as tonic-clonic. You can have a partial seizure, an uncontrolled muscle spasm, or a convulsion while the patient's fully alert. People don't often realize that patients can be alert and then part of their body is doing something weird, and the other parts of their body are just fine. I went on a seizure once in which a person was having a seizure only on one side of their body because it was focused, the actual electrical activity was focused only in one hemisphere of the brain. So on one side of their body they were seizing, the other side of their body they were not. Some of these seizures are as easy as like a little petit mal seizure. And a petit mal seizure, a lot of times people will discuss as oh, well, they're just spacing out, and that may not be the case. We'll talk a little bit more about that. So causes of seizures: hypoxia, stroke, traumatic brain, toxins, and hypoglycemia. We talked about hypoxia before, and we've talked a little bit about hypoglycemia. So hypoxia, they don't have enough oxygen, or hypoglycemia, they don't have enough sugar to the brain. The brain can't handle that, and it has a bit of an issue. A stroke, If you have an area of the brain that's become hypoxic, or you have an area of brain that's under a lot of pressure because it's bleeding around it, that can cause that seizure. Traumatic brain, so part of the brain's been bounced around in there and either bleeding or bruised. And then toxins, like I mentioned before earlier in this lecture. Toxins can get in there and they can disrupt the normal activities of the brain tissue. Brain tumors occasionally will cause seizures as well. These are generally slower growing. When we talk about brain trauma, we talk about a lot of times there's extra pressure building up in or around the brain. Brain tumor is much the same way, but the brain tumor is a slower onset. It takes a lot longer. They may complain of headaches and difficulty seeing and maybe losing some of their faculties, but it's over longer periods of time. Congenital brain defects. So they may have something that didn't form correctly in their brain. An infection, and sometimes they're idiopathic. We have no known reason why this even happens. And then the most common cause would be epilepsy. Epilepsy is just kind of a disease process. A lot of times it's a process of exclusion where they say, we don't really know why, but you occasionally have these weird episodes in which you have excessive electrical activity in your brain. Epilepsy is characterized by seizures being their main sign or symptom. So scene safety during a seizure disorder. Multiple patients seizing at the same time, this should be a major red flag. People don't sync up their seizure activity. What is probably happening here is there's something about the scene that has caused this. So chemical weapons, some weapon of mass destruction, maybe could be drugs, could be other toxins that aren't necessarily related to acts of terrorism, but that would be a red flag that, hey, there's multiple people seizing. That's not right. Take appropriate precautions. Get your butt out of there. Get somebody with some hazmat suits and get these people evacuated, decontaminated, and so on. Additionally, before we move on to doing some of the assessment, we need to protect our patients that are having seizures. So if somebody's seizing sitting up in a chair, it probably would be best idea for us to move them to the floor and then put something between their head and the floor to try to protect them a bit. Move things away from them to keep them from hurting themselves. So other things to ask: what was the person doing before the seizure started? Sometimes this actually comes in handy. For the most of the time it's they were sitting there in the chair, or they were sitting there looking at something in the store. So a lot of times it doesn't actually have anything to do with it. But once in a while, we might have somebody that tells us, well, they were kind of stumbling around a half an hour ago, and we got in the car, we took off, and all of a sudden they went unconscious and started flopping around. Well, stumbling around 30 minutes ago, that's got to give us an idea, hey, there was something going on here prior. So let's dig into that a little more. Exactly what did the person do during the seizure? Did they just lay there? Did they flop around? Did they get tense? Did they foam at the mouth? Did they lose control of their bowel and bladder? How long did the seizure last? Most of these last 30 seconds to a couple of minutes, and then they're done. And then what did the person do after the seizure? Well, if we're talking about a grand mal seizure or tonic-clonic seizure, they probably laid there and didn't do a whole heck of a lot. But if it was another type of seizure, they may have started coming around and started talking a bit. So finding out what they did after the seizure. When it occurs, like I said, protect them. Loosen any restrictive clothing. I mean, if they've got a necktie on, they're flopping around, number one, the necktie could catch on something and basically strangle them. Or two, maybe it's the necktie that's reducing the amount of blood flow to their brain. Let's increase the blood flow to the brain. Maybe we can get this to stop. Remove the objects that can harm the patient. Protect the patient from injury, but don't hold them still during convulsions. Do not try to hold them down. You can try to pad. You can try to make things a little safer. Do not try to hold them. They have superhuman strength, And that superhuman strength can cause them to break bones if we're trying to restrain them. After the convulsions end, protect the airway. If we can do something about the airway while they're convulsing, maybe we just sit there with their head kind of between our knees or in our lap, and we just hold their jaw forward, doing kind of a jaw thrust for them to kind of protect their airway. After they've stopped seizing, if we need to suction them, we'll suction them. If we need to roll them up on their side, we'll position them in a recovery position. If they have a possibility of a spinal injury, though, then we might want to consider immobilizing them. And then if the patient's cyanotic, obviously keep their airway open, ventilate, suction, oxygen as needed. So oxygen is going to be good for them. If we can provide them with oxygen during their seizure, maybe we hold the mask in front of their face. Just got to be careful if they vomit. That oxygen is going to be extremely helpful. In most cases, seizures last, like I said, 30 seconds to a couple of minutes. If the patient's breathing adequately and their saturations look good, we can go ahead and give them some oxygen, either via a cannula or a non-rebreather. If they're not breathing appropriately, we need to ventilate. Treat the injuries that they can have sustained during convulsions. A lot of times they bite their tongue or bite their lip, so they may have some bleeding. And then transport. In most cases, we need to transport seizure patients. Once in a while, we run into that chronic seizure patient that we constantly have that we may need to, they may not want to go. It's in their best interest to go, be checked out, but occasionally we just get the person who's not going to go, and we got to leave them with somebody who can take care of them. Status epilepticus. It's a term to commit to memory. This is a major emergency. This is a patient that definitely needs to go. This is 2 or more convulsive seizures lasting 5 to 10 minutes or more without regaining full consciousness in between. So status epilepticus is basically a super seizure. These are very high priority. They need immediate transport to the hospital, and we should have ALS if we can. On any seizure, we should probably consider having ALS respond, but on a status, we definitely need ALS to respond. Paramedics do carry sedative agents that can stop seizure activity, and so by getting ALS there, they can hopefully minimize the any long-term effects of having a seizure. Stroke. Stroke is the death or injury of brain tissue from oxygen deprivation, or essentially this is cerebral infarction. So part of the brain is dying now from the stroke, just like a myocardial infarction in which part of the heart's dying. This causes either blockage of the arteries supplying part of the brain or bleeding from a ruptured blood vessel in the brain. So those are 2 major categories of stroke. Most of them are a blockage. A few of them are bleeding. In very general terms, people who have blockages generally come out of them alive, hopefully with minimal lasting effects, but we certainly see people a little too late in which they are permanently partially disabled. People who have a bleed generally don't fare as well. Many of these people will die from the bleeding stroke. So signs of a stroke may be one-sided weakness, or what is called hemiparesis. And that hemiparesis is very common in a lot of strokes. Headaches. Headaches can either be, most of the time they're from bleeding, but they can also be just from the blockages and from the hypoxia in the brain. But the one-sided weakness is very common when you have a person who has a stroke that's blocking arteries on one side of the brain. And it's actually the hemiparesis, the side that's weak, is the opposite side of the brain that is affected. So if you have left-sided weakness, it's actually the right side of your brain that's having the stroke, and vice versa. Other signs or symptoms of stroke to go along with this. Confusion, altered mental status obviously, dizziness, numbness or weakness or paralysis. And this is normally one-sided, but it can be both sides. Loss of bowel or bladder control, that can go with seizure as well, of course. Impaired vision, high blood pressure, difficult respirations or snoring. And the snoring respirations, unconscious snoring respirations, are very typical with bleeding strokes. Nausea or vomiting, seizures, unequal pupils, that's kind of key there, headache, loss of vision in one eye or one field. So sometimes people say, well, when I look out of both eyes, I can't see anything from the 12 o'clock to the 3 o'clock area because a part of their optic nerve is being injured. And complete unconsciousness. The unconsciousness is fairly uncommon for most strokes, except for the bleeding strokes, in which it becomes pretty common pretty quickly. So communicating with a stroke patient, it's often difficult to communicate with a stroke patient for various reasons. Number one, they may not be able to form words. Secondly, they may not be able to use the appropriate words. Or thirdly, they may not be able to understand what you're saying. Most times they can understand what you're saying. It's just what they try to get back to you they have difficulty with. So the term aphasia is a general term meaning actually aphasia is no communication. The term dysphasia is difficulty in communication. So dysphasia is difficulty. Aphasia is no communication. They're unable to talk back to you. Don't confuse that term with phagia, which would be Phagia. The phagia has to do with eating. So dysphagia would be difficulty eating, where dysphasia, like phrasia, but would be difficulty communicating. TIA, this is a transient ischemic attack. This is kind of like the angina pectoris is to a heart attack. Usually TIAs are kind of the temporary warning signals ahead of time of having a stroke. This causes a lot of stroke-like symptoms. Sometimes you would bet a paycheck that, oh, this is a full-blown stroke. And next thing you know, the person's acting perfectly normal. So this can be either from like a small temporary blockage in the circulation, whether it's a small clot, maybe there's some sort of a brief spasm of an artery in the brain. These symptoms will resolve when that clot either breaks up, moves on, the vessel stops spasming, and you usually will have complete resolution within 24 hours. A lot of times even sooner than that, and with minimal treatment. But it is a warning sign a lot of times. They say you have TIAs, you should suspect that there's a probability of a stroke coming sometime soon. Now, to assess a stroke, we have a very easy tool to use that's fairly accurate. We use something called the Cincinnati Pre-Hospital Stroke Scale. I like to call this the drift, the droop, and the dogs test. So what this is we're testing three major things. The more of these things they have, the greater risk they have of actually being a stroke. So the first thing we're going to ask them to do is ask the patient to smile, show us your teeth. So when they ask them to smile, and sometimes that backfires on you. You ask them to show you their teeth, they point at the nightstand at the denture cup. But ask them to smile, give you a big smile, and you're looking at their face to see does it work symmetrically. And we can see from this picture here, this gentleman can smile only on the right side of his face. The left side of his face he doesn't have much movement on. So the stroke patient is more likely to show this abnormal response. So that would be droop, facial droop. The drift, this is the pronator drift test. We're going to ask the patient to close their eyes and extend their arms straight out for 10 seconds and put their palms up. The stroke patient most likely is going to have one arm flip back over and start to drift downward. If the patient doesn't close their eyes, this test will not work because they will see that their arm is moving and they will correct it. But if they close their eyes, they don't realize that the one arm flipped back over and is now going back down. So close your eyes, hold your arms out in front of you, and put your palms up. And then have them do that for 10 seconds. Somebody having a stroke most likely will show the same result as shown here on the screen. And then dogs, this is this ask the patient to say something very simple that people would commonly know. The sky is blue in Cincinnati. I imagine that's what they use in Cincinnati where they invented this. But I like to just have them say, you can't teach an old dog new tricks. Everybody knows that phrase. Everybody knows that saying. It's not confusing to people. And you ask the patient to say that back to you. And they either will mix up words, they won't be able to get it all out, or they may not be able to say anything at all. And that is an abnormal response. It's not tricky or confusing, so they shouldn't have any trouble with it. So drift, droop, and dogs, facial drift, arm drift, pronator drift, facial droop, and you can't teach an old dog new tricks. You have one of those, you have a very high risk of it actually being a stroke. Two of those, you're almost at 100%. So for a conscious patient who can maintain their own airway, we are going to try to keep them calm and reassure them. They're going to be very frightened by this. Monitor their airway as necessary. Administer high concentrations of O2 or concentrations of O2 that fit their pulse oximetry, and then transport the patient in a semi-sitting position. For an unconscious patient or one who can't maintain their own airway, obviously we need to do this. We're going to need to do a manual stabilization of their airway. Consider putting in an oral or nasal airway. Remember, if they've had any nasal trauma or you suspect that there's a possibility of any head trauma, that the nasal airway is out. Provide high concentrations of O2, and then transport the patient lying on their affected side. We transport them on their affected side because that is the side that is most likely to get hurt. So you put them on that affected side and it helps stabilize it and keep it from becoming an issue. We're going to transport suspected stroke patients to hospitals with the capability for managing a stroke patient. You need to look at your local protocols and find out who are considered the appropriate stroke centers in your area. Capabilities must be a CAT scan or a CT scan. A CT scan is needed to really quickly check them to see, is there a bleed in their brain? If there's no bleed in their brain and the stroke is still fairly early in the process, there are certain clot buster drugs that the patient can get that can hopefully resolve this. But if there's a bleed in the brain, you give them the clot buster drug, the patient dies. Try to determine and document exactly when the onset of symptoms were. Sometimes that's not possible. And document contact information of a person if that patient provides, if somebody other than the patient provides that onset, so that they can interview this patient or this person a little more to find out better information. Kind of pulling into the station here on this one where we talk about dizziness and syncope. Dizziness and syncope, these can indicate serious or life-threatening problems, but sometimes they're really just very minor issues, but we're going to err on the side of caution. It can be impossible to diagnose the true cause of syncope, but in many cases it's actually an underlying heart problem. So dizziness, this is a common term meaning different things to different people. Vertigo is a sensation of your surroundings spinning. The medical term for dizziness is technically vertigo. Lightheadedness, this is a sensation that you're about to pass out or pre-syncope. So these things can happen for a large number of reasons, whether that is medications, maybe it is you're shocky, you're dehydrated, sometimes pregnancy, sometimes it's underlying medical conditions, diabetes, etc. Syncope, this is a brief loss of consciousness with a spontaneous recovery. And like I said, usually it takes you about as long as it takes to hit the floor before you start to wake back up. Usually it's a few seconds to a few minutes and they're waking back up. It just basically, once the patient gets into a horizontal position, blood flow returns to the brain. The brain then can kick back into gear and work like it's supposed to. And patients will often have some warning that a syncopal episode is about to happen. They may tell you, oh, I feel like I'm going to faint. So some causes: hypovolemic, meaning they're low on their volume, they're essentially dehydrated. Metabolic, they may not have the sugar or the other hormones to keep things going. It can be environmental or toxicological. There are a lot of medications that can cause this. And then cardiovascular, which is actually the most common cause in most cases, is that they had some sort of a brief change in their heart rhythm. So hypovolemic, low volume causes dizziness. They just don't have enough. You got a 6-liter container with only 5 liters of fluid in it. It's hard for that blood to go uphill against gravity. So they may have a bleed that they're not aware of. Maybe their intestines are bleeding. Maybe they have some sort of an internal injury or an aneurysm. Metabolically, this can be brain chemistry issues. Inner and middle ear problems often will cause dizziness. Not as many times will it cause syncope, but often causes dizziness. So they have a middle ear infection or an inner ear infection. It throws off the balance. You have small structures inside your ears that basically help you maintain your balance. And it's basically like weights on little levers. And when the weight shifts, it shifts the levers. The levers shift. They send a signal to the body saying, hey, we're changing position here. Alcohol and drugs, we've kind of talked about that. Cardiovascular, bradycardia or tachycardia, very fast or very slow heartbeats will change the cardiac output and can lead to syncope. One of the very common causes of syncope is a vasovagal syncope. It's thought to be the result of stimulation of the vagus nerve, which signals the heart to slow down, and it decreases cardiac output. The most common place that this happens is on the toilet when somebody's trying to have a bowel movement. They're sitting on the toilet trying to have a bowel movement. They bear down. Those muscles kind of stimulate the vagus nerve. The vagus nerve slows the heart down, and wham, you pass out. So assessment, rapidly identify and treat any life threats that you come across. So breathing, circulation, airway. Gather important information. You may be appropriate to also check blood sugar here. If you have an altered mental status, one of the easiest things to do, if you have the capabilities, is check the sugar. Ask the patient if they've ever had an episode like this in the past, and then ask them what do they mean by dizziness. Tell them to describe a little bit more how they feel. Was there any warning signs? When did it start? How long did it last? What position were you in when the episode occurred? Were you standing? Were you lying down? Were you sitting? Most people don't pass out while lying down. Are you on any certain medications? Any other signs or symptoms? Did you witness any unpleasant sight or experience a strong emotion? That could be a psychological reason for this to occur. Did anyone witness any involuntary movements? So did they possibly have a seizure? It's possible. They may not realize they happened. So your treatment, oxygen based off of their oxygen saturations. If you don't know, high flow. Call for ALS. Let the paramedics show up, put a cardiac monitor on them, see what's going on with the heart. Loosening tight clothing, particularly around their neck. Lay the patient flat. You can even put their feet up if necessary if they were not injured. And then they may have some injuries. If they fell from standing, they probably hit something on the way down. Double check to make sure there's not any head, neck, or back pain, and then treat any little bumps and bruises. So, is a seizure or syncope a symptom of a larger problem? And in many cases, it kind of is a initial heads up that, hey, you need to look deeper. There's a video on TIAs. All right, so our chapter review. The diabetic emergencies are usually caused by poor management of the patient's diabetes. May be brought on by hypoglycemia, which is low blood sugar. And the chief sign of hypoglycemia is very quickly, acutely altered mental status. When a patient has altered mental status and history of diabetes and can swallow, we can administer oral glucose. If we're able to check a blood sugar and see that the blood sugar is plenty high, we don't rarely need to give glucose, but that's going to depend on our protocols. Seizures can have a large number of causes. Assess and treat for possible spinal injury, protect the patient's airway, and give them O2. Gather information about the seizure and pass that along. Strokes are caused when we either block or rupture an artery in the brain. Those can include altered mental status, numbness or paralysis on one side, difficulty speaking. Stroke patients need open airways, appropriate O2, and then determination of when their signs and symptoms began, and quick transport. Dizziness and syncope can have a variety of causes. Generally, we're going to treat those with O2, loosening any clothing around the neck, and then placing them flat with the raised legs if there's no reason not to, and treat injuries as necessary. Determine if the patient's altered mental status is being caused by hypoxia. Hypoxia is easy to fix. We can give them O2, we can give them lots of O2, and generally take care of many of those issues. If the patient is hypoglycemic, and determine if their mental status is alert enough to allow you to give them something to eat. Assess the seizure patient to determine if you need to ventilate or suction their airway, and determine when the symptoms of the stroke began. So some questions for you to consider. List the chief signs and symptoms of a diabetic emergency. Go back and review that list that we talked about earlier. Explain how you can determine the medical history of diabetes. Remember, that's potentially from the bystanders, from the patient, from the family members, and from your scene clues. Explain what treatment may be given by an EMT for a diabetic emergency, and in most cases this is something, an oral sugar source. Explain the care that could be given to an conscious or an unconscious patient with a suspected stroke. Normally this is being very supportive, protective, and rapid transport. Explain the care that should be given to a patient with experienced dizziness or syncope, very much the same. Your critical thinking question: you have a 62-year-old male witness having a tonic-clonic seizure. Find him actively seizing, his skin is pale and moist, and slightly cyanotic. Discuss the immediate treatments necessary. If he's still seizing, remember we're in a protection mode. We're going to protect him by moving him to the floor, moving anything that he could potentially get hung up on and tangled up in. Try to protect him from banging his head on the floor. Do not hold him down. As necessary, if we can keep his airway open, that's great. Otherwise, as soon as he's done seizing, we need to make sure we manage his airway, manage any injuries that he got in the process, provide some O2 whenever we can, and then we can check him. If we have the capabilities of checking the blood sugar, we would check his blood sugar and then get him transported as soon as possible.